So I'll now invite up to the stage Professor Nick Graves. Nick's he's one of the investigators on CRE Reduce, and he's a professor of health economics at IBI, QUT. He's also academic director of OSHI, the Australian Centre for Health Services Innovation, and the academic director for his own Centre of Research Excellence. He's going to be talking to us about his centre and health service delivery considerations for combating superbugs.
All right, thanks for that nice introduction, Jason. So I lead the Australian Centre for Health Services Innovation, and we're here to really build capacity for health services research among clinicians. Jason was an inaugural clinical director, so we focus on simple improvements to health service based on evidence around high-value care, low-value care, better organisation of our scarce resources. So we're trying to bring some rationality and economics into the way we organise our health services. And it's fun, it's challenging. But the challenge for infection control, I suggest, is a challenge that the whole health service faces, and it's one of allocation efficiency. So we know we've only got so much money to play with. That's become increasingly clear in the last few years, and we have to use that money wisely. I'd like to show you 3 different organisations of, say, a hospital. So this hospital decides to spend 60% of its resources on administration, 5% on patient safety, 10% on surgical, and so on. And so for that investment of, say, 100 units of cost, which is all we've got, we can enjoy 80 units of benefit. And you'll see, on average, it makes patients relatively unhappy. There's not a large amount of health or benefit or value flowing from this decision to allocate our scarce resources. So as an economist or a health services researcher, we think about better ways of using our scarce resources. And this is the second allocation. So we've cut the administration massively, we've boosted our surgical, medical and diagnostic services, and we're still spending the same amount of money, 100 units of cost, but we're now getting 200 units of benefit. So we're getting over twice what we were previously. And we're still not happy. We still think we can squeeze some value out of our scarce resources. So we're going to reallocate again. And here you can see we've increased our patient safety budget in order to fight superbugs. So we've increased our investment in infection control and patient safety. And now we're enjoying extra benefits, 270 units of benefit. And you'll notice that we've saved some units of cost because we know that preventing infections will free up bed days and save costs. So this is really how economists think about organising healthcare services. We want to really aim to we want to choose an organisation of services, or in this case, infection control services, that deliver the best health returns, given that we live in a world of scarce resources. So that's the background to my talk. I'd like to talk about 3 studies now that we've completed in our CRE, which is finishing at the end of next year. The first piece of work was led by Kate Holton, and she looked at the cost-effectiveness of different types of antimicrobial catheter in the intensive care unit, and she particularly focused on addressing uncertainty in the decision. And Kate compared all patients getting uncoated catheters with chlorhexidines, silver sulfidizing coated catheters, 2 versions of those, a silver platinum carbon catheter, and a minocycline rifampicin coated catheter. And you can see that the effectiveness increases as we move down. Number of infections avoided increases. It frees up bed days, so it's saving our costs. So we're saving costs while we're preventing infection. So all these options sound fine. But the best option is the minocycline rifampicin coated catheter, because this graph shows it gives us the largest cost savings and the greatest health benefits in terms of effectiveness and quality gain. So this seems like a fairly simple outcome for decision makers. But when we included all the uncertainty and all the information that allowed us to make these predictions around mortality, cost, effectiveness, quality of life outcomes, patient throughput, all that uncertainty, and included that in our outcomes, we found that all these catheters sat on top of each other in terms of what the cost effectiveness outcomes really were. So once we included uncertainty, it was very difficult to pick them apart. Minocycline rifampicin coated catheters did win, but it wasn't clear. So the point I'm trying to make with this study is that decision-making can be highly uncertain. What we have to do is assemble the best information we can for decision-making. We either jump on board and adopt our decision, or we reject our decision, or if we're still unsure, which happened in the case of these catheters, we have to postpone and think about the value of collecting new information which makes that decision-making process clear. So it's a really nice way of setting a future agenda for research. So that's the first project I'll feature. The second one was led by Caterina Meroloni, and she looked at preventing infections in patients that had a total hip replacement. So this was driven by a large meta-analysis. We harvested data on 125,000 total hip replacements for patients between 64 and 75 years of age, and we had data between 1 and 8 years of follow-up. We did a network meta-analysis, which allows us to compare studies that weren't head-to-head trials, so we can borrow strength across studies, and we can really understand all the evidence in one cohesive framework. This was a Bayesian framework, and it allowed us to really do a thorough synthesis of the evidence. I won't go through the whole network, but I will focus on T6 and T7. Now, strategy T6 is where we administer systemic antibiotics. The patient gets antibiotic-impregnated cement, and their surgery is done in a theatre with conventional ventilation. Now, T7 is exactly the same, except we've added in laminar airflow over conventional ventilation. And this was, I think, an important result. If you see the bottom row of this table, T6 versus T7 has an odds ratio of 1.96, which means that adding laminar airflow in almost doubles your odds of getting an infection in your total hip, which is not very good for people that like laminar airflow, sell this product, and generally get behind this technology. You will notice that the credible intervals are wide, so this is an uncertain estimate, but there does seem to be an effect size there. So when we push this data into a cost-effectiveness model, and this is a picture of the laminar airflow system blowing all the flakes of skin and the crud off the surgeon's face straight into the wound, and also cooling the patient down very nicely, which may be the two mechanisms which are happening here. But when we add laminar airflow into our health services, which is an expensive thing to do, we're increasing our number of infections every year by 179. They cost between $30,000 and $50,000 to manage. 4 extra people are dying, and we're losing 139 quality-adjusted life years. So for decision-making, this is a very clear signal. We shouldn't be using laminar airflow. But it's very difficult. If you present these data, people don't want to change what's already in place. So we think of decision-makers as rational, but they're not rational. Decision-makers fear uncertainty, and they fear making a mistake, and no one has been game on the basis of this evidence to think about laminar airflow. So doing nothing is perceived as sort of a safe and sensible thing to do in the face of uncertainty. And I would disagree. I think doing nothing is its own positive decision that you have to really be responsible for the consequences of. So that's the second insight. The third is a study we finished around the cost effectiveness of the National Hand Hygiene Programme. And many of you would have been part of this programme. It was rolled out by Lindsay Grayson from the Austin Hospital with Hand Hygiene Australia and the Australian Commission for Safety and Quality in Healthcare. So we got competitive funding to do a cost-effectiveness study of the National Hand Hygiene Programme, and we assembled a strong research team, including ID doctors, health economists, epidemiology, microbiologists, and so on. So we had a good health services research team looking at this question. I won't go through the methods, I'll go straight to the results of our study. So we recruited the 50 largest hospitals in Australia, about 24,500 beds, about 1.3 million admissions. The next column of data shows the baseline starting rate for SAB, Staphylococcus aureus bacteremia. And you'll see the highest rate was in New South Wales at 2.6. The lowest rate was in Tasmania at 0.9. And this is per 10,000 bed days, so it's quite a rare event. But the National Hand Hygiene Programme worked. It reduced rates by 17% in Queensland, 28% in the ACT, 11% in New South Wales. It had no impact in Tasmania or Western Australia, so there were some benefits of having the National Hand Hygiene Programme. So at face value, this looks like a smart thing to do. But when you think about the costs of implementing this programme, and it wasn't cheap to implement, the story changes somewhat. So these are the cost-effectiveness results. We'll see in Queensland, every year, the addition of the programme reduced SAB by 27.5 cases, but it cost us net $355,000. So this takes into account all the cost savings and the cost of implementation. So the cost per life year gained is about $9,000, which isn't too bad. In ACT, there was a large reduction of almost 10 cases per year at a modest net cost of about $14,500, so over $1,000 per life year gained, which is good value for money. In New South Wales, it increased to $33,000 per life year gained, which is less good value for money. PBAC starts to get twitchy at about $40,000 per life year gained. That's their threshold for good value in healthcare. So in South Australia, we exceeded that threshold, $64,000 per life year gained. And in Tasmania and Western Australia, where there was almost no impact, the cost per life year gained was over $10 million and $63 million. So all we did really there was just spend money. Now, this was not the answer that the policy partners were interested in. Overall, the National Hand Hygiene Programme costs about $3 million per year, and it prevents about 66 cases of SAB. So overall, on average, nationally, it's about $30,000 per life year gained. And we had an interesting experience with our policy partners, the Australian Commission and Hand Hygiene Australia. So before the findings, it was a case of Dr. Jekyll, and there was a lot of great support for this project. It's a good project, Nick. The team's fantastic. You're doing an important study. But when we presented the results, which are unbiased and an impartial look at the data, there was a real problem with these results. The methods were attacked. We're taking a risk with this evaluation. We're very concerned about the methods. It's clear you have no idea what you were doing. And I think what's driving it was the final quote, which is information we got from one state, was that the minister was heavily invested in the hand hygiene programme. So we were going against the political preference. And lots of other preferences. So the lesson we learned from this is actually do the research before you make the adoption decision. In this case, the adoption decision was made, hand hygiene, national hand hygiene was going to become a priority, and the evaluation followed on, and it's the wrong order. You need to do the research before you invest the resources. So that was our third example. And just to finish, I'd like to cite, or just mention a very nice paper, you're probably aware of it, by Joe Coast and Richard Smith, where they tried to look at the true cost of antimicrobial resistance. I've tried to look at some of the cost-effectiveness items around making different investments around infection prevention and infection control. But this paper really is a nice commentary on the true cost of resistance. And their take-home message is that the current estimates are grossly undervalued, with antimicrobial resistance at $55 billion per year. They sort of debunk these estimates, and in using one example of total hip replacement, suggest that the costs just around that one patient group probably exceed $380 billion per year. So we're not really valuing the cost of antimicrobial resistance appropriately. So the economic analysis we do around patient safety, around infection control and treating infections appropriately probably needs to be thought through. So that's all I'd like to say. Thank you very much.